come back to that when we come on to you later. I'm going to move on because I'm running slightly late. Apologies. Gary, I'm going to turn over to you. So Gary is the adult psychologist at King's, and he's going to talk about the role of IMPARTS in delivering a holistic sickle cell service. Gary, are you there, and do you want to share your screen?
I'm here. Thank you. Thank you. Let me see if I can do so. Okay, everyone. So I'm going to speak about particularly the role of IMPARTS in delivering a holistic sickle cell service. And first of all, thanks also to Umar Utakun, who is with us as an honorary assistant psychologist and has been absolutely pivotal in implementing IMPARTS within our clinics. So IMPARTS, it stands for Integrating Mental and Physical Health Research, Training and Services, which is a King's Health Partners initiative. So it's quite broad, and it's all about the agenda of joining up mental and physical health. And as part of that, there's a screening system which consists of questionnaires which are routinely given to patients to complete. So this has existed for quite a number of years, not within haematology clinics, but it appeared an obvious thing to connect with. There was a lot of things that were particularly persuasive about it, just how the technology was already set up, the links to electronic patient records. So we launched it in March 2019, and we decided to begin with patients attending for annual reviews, or patients who are new to the service or transferred from a different hospital or from a district service. Really, patients will be getting the questionnaires approximately once a year, aware of fatigue of filling out questionnaires too regularly. So to begin with that frequency. So there's a huge number of questionnaires that one could administer. It's totally sport for choice, but one has to be aware of how exhausting it could be for a patient to complete all of these. So some of them you have to administer. So the PHQ-9, the Patient Health Questionnaire, is a measure of depression, and the Generalized Anxiety Disorder Scale is a measure of anxiety, and they are two of the core questionnaires. Questionnaire on smoking, selected one on sleep, the Jenkins Sleep Questionnaire, pretty brief, just 4 questions inquiring about sleep disturbance, which appeared to be a significant problem in the patient group, so I thought it was important to assess that. The Work and Social Adjustment Scale gives quite a lot of information on functioning in different areas of a person's life: education, leisure pursuits, relationships. Brief pain inventory, particularly this is given to patients who have said that pain has been an ongoing and significant problem in their life over the past 3 months. And the 3-month period of time is significant because when pain has persisted over 3 months, it's then seen as chronic or persistent pain as opposed to an acute pain episode. So really wanting to try to see these people that are living with pain on a daily basis. And finally, a questionnaire on medication use, but just for patients taking hydroxycarbamide and Exjade. So why are we bothering doing this, you may ask? And well, I think the reason is really clear. It's been really well established that when patients have a comorbid mental health problem, this results in poor outcomes, sometimes through direct physiological mechanisms, for example, increased stress hormones, cortisol. It could be decreased adherence to treatment, engaging in unhealthier behaviour such as smoking, poor diet, lack of exercise. Especially if someone is depressed and has low motivation, poor self-care perhaps. When there's comorbid mental health problems, it predicts length of hospital stay, more outpatient visits, poorer quality of life, greater disability, increased admissions and healthcare costs, poor concordance with treatment, and poorer health outcomes. And it predicts functioning actually better than medical variables do. So someone may have a relatively milder form of sickle cell, but yet if they have the presence of anxiety or depression, that's more likely to impact upon their functioning. So screening takes place in clinic, or it did, until COVID hit in March. So we were giving patients iPads, first of all given an information sheet when they arrived at the appointment, explaining the purpose of the screening, explaining that it was entirely voluntary, that they could decline to do so if they wished. They were given an iPad, which would link, the questionnaire would then, once done, would go immediately to their electronic patient record, so that it will be available to be reviewed by the haematologist during the consultation, and support given to patients to complete it, particularly if they have any visual impairments, any kind of disability or language needs. And again, I think this has been, we've been so lucky to have Umar on board with this. She came along at just the right time, and I think we would not have had the same definitely kind of completion rates without her there to oversee it, to talk with the patients, to explain it, to assist them, also with maintaining a database of the scores and liaising with the IMPARTS team, particularly when there's any technical problems, which do occur from time to time. So between March 2019 and March 2020, when we stopped, 201 patients completed the screening, only 3 declined, and we was able to get also some quite useful feedback during the administering, as they would have conversations with Umar and her observations. So most were happy to have their psychological and other concerns addressed. A substantial number of patients expressed to her that frustration they felt living with a very disruptive yet largely invisible disease. Themes of no one understands were quite strong. Some patients felt psychological distress was not relevant to them, but participated anyway. I guess I'm thinking also about Kofi's presentation and the potential for stigma also with if they disclosed any kind of struggles with their mental health. At times, patients emotional during the screening, during completion of the screening questionnaires. Again, I think really it was very important that there was someone there at that time to be able to support them and to elaborate some of that more. This is how it appears when it goes on to their electronic patient record. So the patient would have arrived at the clinic, completed the questionnaire, then it will be visible to the doctor during the consultation. So it can then shape the consultation and introduce a conversation about psychological well-being into that consultation. which, you know, maybe to do so there might be barriers. You know, it might feel a bit difficult how you start to have these conversations, maybe feeling a bit reluctant to open up a can of worms. So here's some way to introduce it into a consultation. And I think as people do so routinely, it becomes more natural and normal to do so. So in this instance, the person wasn't taking hydroxycarbamide or XJ, so they didn't get the medication questionnaire. You can see here, this was on the PHQ-9 measure of depression, so they scored very highly on here. And there's in red, there's some guidance then about what is recommended to do with that particular result. And all of this is really as guidance, really. People vary on how they complete questionnaires. Some may underreport, some may overreport. So it's important to think that this is only a screening part of an ongoing conversation. But particularly if there's any risk issues, it's important then to give some clear guidance to a clinician on what to do. Have I frozen? Okay. Again, then with the GAD-7 on anxiety worry, again comes up with some extra guidance on what to do if they're scoring highly. It also shows this, what's the score out of. So with that one, it's out of 21. With the Jenkins sleep questionnaire, the next one, the score is out of 20. So again, you can kind of see, you get an indication of the severity and how big a problem that is. And smoking questionnaire, as I said, that's one of the ones that is a core one we have to give out. And then one on pain, and especially particularly with this, the brief pain inventory, a score out of 110. So the higher the score, the more significant and interfering the pain is in their life. I mean, all of these sort of data is quite handy, particularly when complete helping people with personal independence payment appeals or applications. You know, you've got something to really quantify the impact upon their life as well, something a bit more objective as well. So I think that can be also helpful, and haematologists tend to feed back the results of this in letters back to GPs as well. So this has been on hold since COVID, but there is moves to now do it remotely, where a link is sent out to patients 24 hours prior to their appointment. So they then follow the link, and then that will take them to the web-based questionnaires. And then that will be visible then to the clinician for the consultation. And if they score positively for suicidal ideation, there'd be a pop-up screen directing them to more immediate sources of help and support. I suppose doing remotely, one of the things that I've said is how important the role of someone there to support people completing it. So I think that's something we have to be very considerate of and mindful of if we're asking these questions, that we can, you know, act upon this and definitely review it swiftly with the patient. The results, just looking at the different domains that are assessed. So out of the 201 patients that were screened, 52 screened positive for possible probable major depression. So that's a prevalence rate of around 26%. And that's a score of 10 or above out of 27 on the PHQ-9. And that sort of 25% seems to be quite a recurring type of figure for people with long-term health conditions. So it's quite in line with that, really, the prevalence rates with other health conditions. And again, it's where you put the cutoff. I mean, it's in some ways it can be quite arbitrary to just say 10 and above. How about for those people with, you know, milder symptoms? And again, so if you have a lower cutoff, then the prevalence rate will, of course, rise. And which is why it's important to have those discussions individually with patients. With anxiety, so 39 rather of the 201 patients screened positive for probable generalized anxiety disorder. So that's a prevalence rate of around 19%. And again, that's based on a score of 10 and above. If you set that score lower, prevalence rates again would increase. As some of the previous literature has shown, and other people's experiences, sleep seemed to be quite a significant problem. So 25% of respondents had a score of 12 and above out of 20. And I think sleep is something that can be quite sort of addressed by things such as workshops and self-help material as well. So there's different booklets that can be sent out, guided self-help. If it's just a problem with sleep, you know, perhaps there's some kind of intervention that can be quite routinely given that could maybe have some kind of an impact on that area. So detecting that need and being able to respond to it. So the functional impairment, the work and social adjustment scale. So 45 out of the 201 patients rated a degree of impairment in their functioning as being in the moderately severe to severe range. So prevalence rate of around 22%. And pain. So again, recall that there was a branching questionnaire here. So it's just for those people that said pain had been a ongoing and significant problem in their life over the past 3 months. So 59% of respondents said that had been the case. And of these, 52 said the pain had been in the moderate to severe range over the past week. So a prevalence rate of 44%, while 60 patients reported the interference had been in the moderate to severe range. So it's separating the severity of the pain with the interference, which can be quite helpful really, because sometimes we might not be able to do so much about the severity of the pain, but we might be able to help people to manage that, to live a life as full as they can, even alongside the persistent pain that they experience. Interpretations of some of this. So the data, and particularly around pain, is really in keeping with more recent findings that pain in adults with sickle cell disease is far more prevalent and severe than previous studies had portrayed, and that most of the pain is actually managed at home. So we only really see a tip of the iceberg, I think, for those who are attending ED, coming to hospital. Majority of people are coping with quite severe levels of pain at home, and this is a way maybe of being able to try to detect this. I think importantly that of the patients with a pain score of 55 and above, 57% also screened positive for probable major depression, while 42% screened positive for probable generalized anxiety disorder. So that comorbidity of depression and pain, or anxiety and pain, and that's really important because there is such an interconnection between pain and, you know, emotional distress. Larger predictors of pain factors than disease phenotype, and result in increased frequency, intensity, distress and disruption due to pain. So if you're not addressing the anxiety, depression, then you really aren't really treating that person in a holistic way. Patient feedback generally has been very positive. So these are some of the responses that Uma is able to record. So very good, covers questions I would have liked to talk about. This screening is very good, and this patient noted previous illness which was related to stress and identified the need to be more educated on how to manage their health. This was a bit of an outlier. Someone really didn't like the brief pain index. I think it was about the rating of the pain on a numerical scale. They found that an insult, offensive, not appropriate. Said that this was a common issue of discontent among other sickle cell disease sufferers. So, you know, that's I guess my kind of response to that would be I'd like to be able to engage with them to get their ideas on how can we gauge the impact of pain on people's lives. Are there other ways, you know, to try to collaborate really in ways that they feel would be more appropriate. But that was quite a low number of patients that said that. Someone said this is too late. I needed this kind of assessment years ago when I was struggling. However, I enjoyed the questionnaire experience, and I'm very glad this is what I'm going through now. Staff, I think, have been I think they're all enthusiastic about it, really. I mean, I think when introducing something new, there's understandably some hesitation. I mean, especially I think about asking about the risk issues, suicidal thoughts. But as I think people have become accustomed to this, I think it's been embraced by the team. So these are some of the things staff have said. There's always a lot to learn from listening to patients, as the range of psychological and lifestyle differences varies, just as the expression of the physical illness varies. I was moved by patient vulnerability, inspired by their resilience, and proud to be part of a service addressing this significant interaction of their whole health. And from consultant haematologist, really flagging up something which my next slide will talk to, about the being able to provide data prevalence rates, which is very important and helpful for building up a business case. But as well as that, it's also enabled to build up a more holistic conversation with service users and given the team better understanding of some of the additional struggles they face. So again, thinking about different things about work, education, relationships, it broadens the topic of conversation in a consultation. I say an additional benefit, it's been used within a business case for an additional psychologist. So it's helped identify the psychological needs within this patient group and highlighted the fact that existing psychology staffing levels are unable to meet this need fully. And, you know, important work that Dr. Heather Rule from Guy's did about looking at ratio of psychologist to patient. Been really helpful making a business case, but the IMPARTS questionnaire data was really also helpful in just flagging up this need. And I'm pleased to say we look like we've been successful with getting another psychologist and also some social work time, additional clinical nurse specialist and a haematology consultant. There are some drawbacks, so particularly with the PHQ-9 questionnaire, some of the symptoms can be inflated by the health conditions. So, for example, fatigue, that could be to do with the fatigue to do with the health condition, or it might be more to do with fatigue in relation to depression. So one needs to take these things apart. Technical issues, so sometimes it hasn't worked, so there's been network has let down, but not very frequently, and when that's happened it's tended to be affecting electronic patient record as well, so not just unique to the IMPARTS screening. The data is held by the IMPARTS teams. That's a bit of a drawback. We have to actually approach them to get the data. So we keep our own database, and Uma is so helpful with this as well, and also being able to link the data to individual patients. So that's one of the things that means that we have to do a bit of additional work to keep track of things. And of course, patient fatigue, filling out a number of questionnaires whilst we try to keep it brief. You know, it still does take a bit of time to complete. So this is just how I keep a bit of an additional database. I won't go into that one. Future developments. So we're looking to introduce IMPARTS. We're well advanced actually introducing IMPARTS into the transition clinic. And I think being able to detect any needs at a young age is really important, because we know that depression tends to be recurrent. And if people are getting that during adolescence, teenage years, early, then you know we can maybe set them on a different course in life that will I think will have a real impact in a positive way. Within the joint sickle pain clinic, also we're looking to implement it there with some more specific questions around pain, and using it as an outcome measure as well, to be able to look at pre and post. So maybe once someone's had some kind of intervention, has there been a change in their scores for the better? So that brings me to the end of my presentation. There's my contact details. I'm very happy to receive emails and discuss with people. But if I end the show now.
Thanks, Gary. That was great. A great overview of what you've done and how you introduce IMPARTS. Again, I just ask for questions in the chat or to put your hands up. But while we're waiting for that, I struggle a bit with the IMPARTS, to be honest, because it's not very sickle specific. And I always wonder why that's being used and not more sickle specific measures. So that's my first question, and maybe we could get Rosella and Kofi just to comment on what they do, which I think is slightly different. And then my second question is, once you find a patient with a high score, what do you do? What interventions do you do? Is there a generic intervention? Would you see them? What happens?
So I suppose the first question is that there's no reason that if another questionnaire that would be more relevant could be used and the IMPARTS team could acquire it, then that could be added. I know there's some of the Ask Me ones are out, which are more sickle cell specific, and if that's felt to be a better way of assessing, then I think that could be added to it, replaced. I think where there's some lack of flexibility with some which are just there, the PHQ-9, the GAD-7, they just have to be done. So unless something changes with the IMPARTS team, we're a bit limited there. But something like a measure of fatigue or mobility, something like that could be added as well. It's just a balance in asking too many questions. So this is the balance of it, really. I don't know if anything Kofi or Rochelle had to say at that point before I move on to your next question about intervention.
Yeah, I was gonna say specifically that that's the issue, but I agree that for anxiety and depression you can use those because you don't necessarily have anything specific for sickle cell per se, but for example, the brief pain inventory, you could sort of substitute that with something that might be more relevant in terms of capturing, because I was just trying to look at that outlier that you talked about, the negative comments, because maybe they didn't see it as being sickle specific, and that's why they might have thought of it that way. So if it's possible to incorporate something more specific, especially when it comes to pain, specifically for sickle cell pain, that would be useful.
And I wanted to add into that, we don't use IMPARTS in our service at the moment, and things like the GAD and the PHQ-9, because we were worried about normal sickle cell related distress being conceptualized as a mental health problem rather than it being a normal reaction to really challenging life experiences. So we were worried about it being quite reductive and potentially unhelpful. So we do give measures, but we also think about having a conversation with people to be able to understand their position and to try and use as close as possible the language that those individuals might use to explain their distress. We were also concerned in some ways about where that data goes and how we could use that and how we could refer to it to keep it being clinically meaningful for our patient population, to make sure that it's guiding our services and maintaining a high quality of care, rather than it being just about a research element. But Gary, it's been interesting to see your point of view on it as well, and I think it's definitely worth us considering across the range of services what outcome measures we do use, but to make sure that those are definitely clinically meaningful. And as you mentioned, with the fatigue that it does cause, we ask a lot of our patients in coming into clinics anyway, and as we know, they're not the keenest people in terms of coming to hospital, and they try and get out of clinic as quickly as they can. So I think ways of being able to promote the idea of emotional well-being and connecting that to physical well-being as well, there are lots of ways to do that.
Mm-hmm. And I think that's something about if a consensus begins to emerge across us about what measures are most meaningful and helpful, I think that will be great. And then kind of comparisons about what's done in different sites, trusts can be made. But I think the IMPARTS is there's the questionnaires, and then there's the sort of process of it as well. So it's been quite helpful to have a little pause on it, really, actually, as well. Doing it for a year, a pause, and then getting that kind of discussion going. And I guess what we do with the results, I mean, it's just a screening, so it's about being able to start having these conversations. So as much as I can, I'd like to be able to empower other members of the team to have these conversations, to actually inquire and get curious and find out more about how these things are impacting upon someone's life. So you've answered this, can you tell me more about that? So it's a way of being able to introduce and open up these conversations. And I mean, not be too tied by just a number. I think it's really important to understand, and it's the beginning of a conversation, I think. But I mean, if someone is really scoring quite high, then and one of the guidance is whether the distress seems to be also linked in with the health condition as well. So that if there seems to be a real interaction between someone feeling the distress because their health is really impacting on different areas of their life, and it's about the health, then maybe that needs a whole multidisciplinary approach. It needs, someone for me to be involved with seeing. But if someone's kind of feels like they're doing fine health-wise, but almost this is a kind of somewhat, has a sort of a slightly separate entity to it, it might be then we can signpost people to different services that exist, which is what we've had to do a bit more because of I'm here just the 4 days a week. I think if we had greater resource, then I think we could engage with more people. But it's about, I think, looking at this and thinking if a lot of people are reporting sleep's a big problem, for example, how can we maybe tailor some kind of a workshop on sleep? If pain's a big problem, maybe we need to do more about that, develop more of a pain management program. So I think it's if it's not going to inform what we're doing clinically, then I'd agree, why are we doing this? And which is why I did that extra work, Uma and I, about really capturing it and keeping our own database and examining that in a way that we wouldn't be able to do if it was held by the IMPARTS team.
Brilliant. Thank you very much, Gary. That was a
Okay.
very interesting discussion afterwards. Food for thought always with these things. Thank you. Excellent. So.